Assalamu alaikum. Today we are going to talk about the management of ruptured abdominal aortic aneurysm. So it's very important to know the phases of care for these patients and essentially where this pre-hospital state, where's the patient at, who's taking care of the patient, is the patient in another hospital, is the patient being taken care of qualified physicians, etc. It's very, very important to help guide the treatment. Direct transfers, as a physician who's accepting transfer, you need to know a lot of information about the patient. You need to know what kind of rupture. I've had transfers and I've got burned before where they said it's ruptured aneurysm and turned out to be type A dissection. Some physicians don't know what the difference between that, unfortunately, or basically it's very important to know what exactly going on with the patient. Preferably you can have images. If there's no access to imaging or there's no way to can transfer images, you can at least ask them to show a text with a video of the CTA and so forth. So it's very important to know that information, because you could have a ruptured thoracoabdominal aneurysm and your facility is not capable of taking care of that. So you want to make sure before you go into trouble and transfer a patient, you can actually take care of that patient. If it's patient in the emergency room, how is the patient is doing? A lot of times these patients come with abdominal pain, back pain. They come surprisingly also. I've had few came in as a trauma activations. They had syncope and they fall, and they found him to have rupture aneurysm on CAT scans and so forth. Then you have, once you see a patient with ruptured aneurysm, then the next question would be, what is the risk, or you have to stratify the risks for patient survival. Can this patient survive or not? If the patient had 2-3 CP code blues, he will likely not to survive. Is the patient 95-year-old, 96-year-old? Discussion needs to be held with the family. So it's very important to stratify the risk and see what's the likelihood, if you do open surgery or endovascular surgery, if you do whatever you do, that you actually can help the patient survive with this procedure. Also, you need to know your capabilities and ancillary services. You need to know, whether you have OR versus hybrid suite versus C-arm. Do you have experienced anesthesiologists that can do sedation, then can do essentially general anesthesia as well? You have to have blood bank that can provide you with blood. If you do open surgery on these patients, sometimes you need a lot of blood and a lot of blood products, such as platelets, FFPs, cryo, so forth. Also, you need to know whether you have a good ICU management. You can do the best operation, and you don't have good ICU, the patient will die. You need to be aware of these complications that can commonly happen with these patients. If you do EVAR on a ruptured aneurysm, you have to watch for compartment syndrome. They can have compartment syndrome. Less likely that they will have ischemic colitis. Ischemic colitis is more common in an open surgery. Endoleaks, type 1A endoleaks, so forth. So you need to be aware of the complication. Essentially, the single most important issue, I think, you need to have a team in place. So you need to have a good anesthesiologist, good ICU doctor, good nurses. You need to have inventory. You need to have a blood bank. So team approach, you have to get. It's not just the surgery itself, but rather than just having a system in place where you can take care of the patient in all phases of treatment. And then once you're done, you need to send these patients to rehab and have access to that and so forth. This study is done in multiple institutions in Northern California and the state of Washington. I looked into the guidelines for transferring patients with ruptured abdominal aortic aneurysms. So first of all, if there's a vascular surgeon on site that is capable of doing these procedures, the patient should stay there and should be done. If there's no vascular surgeon, then you need to transfer the patient to another facility where they have that expertise, but you have to make sure that the patient is stable enough to be transferred. So, and then once you transfer the patient, permissive hypotension is very important to maintain blood pressure between 70 to 90. You do not want to over resuscitate these patients, because if you give them too much fluid, they're going to bleed out if they have contained rupture. So it's important to do a permissive hypotension. And my rule of thumb for these patients, if they're mentally okay, you're fine, even if their blood pressure is low. Transferring a patient who had multiple cardiac arrests is a futile care. So these patients probably should not be transferred. In transit care, the patient should have 2 good IVs, permissive hypotension. It's really the key role here for this issue, for transferring those patients. Rupture aortic aneurysms, so mortality is about 85% outside the hospital, 66% before reaching hospital or without an operation. Perioperative mortality for open repair is about 41 to 80 to 48%. Mortality has not really decreased in open repair even for the past 20 years. This is just a quick slide that shows the relationship between the size and the likelihood that the patient will rupture abdominal aortic aneurysms. So the bigger the size, the more chances that, or annual chances, that patient would rupture. It approaches about 8% when you have an abdominal aortic aneurysm more than 7 centimeter. So it's very important, if you are in an institution that takes care of these patients, to have an algorithm or protocol in place. System protocol makes a difference. It has been shown in multiple studies that improves survival. So overall, marker for good quality of care is 18% in the studies. Mortality basically in institutions where they have an algorithm to treat these patients and they have team in place. In those institutions where patients come random and treated by a surgeon, they have almost double mortality. Not quite double, but it's very high. This slide contains data from Harborview Hospital for outcome with rupture abdominal aortic aneurysms after implementing a protocol to treat these patients. They implemented the protocol in 2007. In 2012, you see the mortality decreased for more than half, so from 57.8% to 25.3%. So mortality really, persistent protocol is very important and works well. Again, the same data from Stanford University, pre-protocol and post-protocol, in all in open repair EVAR, and even with the old comer, has decreased after implementing protocol. So this is a score, risk score was developed by Harborview Hospital, Dr. Stern, where they actually had several parameters such as pH, age, creatinine, and preoperative systolic blood pressure, and the numbers are there. If you have low pH, less than 7.1, you get 1 point. And the area under the curve was actually 0.76 compared with 64 for the older scores such as Robinson and Glasgow score or Edinburgh score and so forth. So what they used this score for, basically prediction of survival in these patients. So if you have 0 point, your likelihood to survive, or your patient's likelihood to survive, approaches 72%. 1.78. So 2 points is less, 63, 3 points, 30%. But here's what's the most important thing. So if you have 4 points, it's 0%, the likelihood that the patient will survive. So based on this score, I think it's important to stratify the risk and then have a conversation with the family, with the patient, and see if your care is going to be futile or give them adequate risk stratification. And basically, again, this what we talked about earlier. So they have modified this score because they added essentially instead of just adding a pH, because the pH was essentially difficult sometimes to get. You need a blood gas. They added INR, and INR more than 1.8. Basically, they found when they substitute the INR with the pH, they found that it has the same usefulness without compromising the accuracy of predicting 30-day mortality after rupture AAA. So instead of just having pH, they added INR, just because pH sometimes is difficult to get immediately. There are other risk scores available, which predictors as shown here. You can use whatever score works for you, but I really think that the Harvard score is one of the simple and easy calculate. You can calculate this easy and has a fairly accurate, basically based on their studies. So what do you do with these patients when you get them to the OR? Local anesthesia, does it make a difference? Yes, it makes a difference probably. So there's a study here again with 90 rupture aneurysms. General anesthesia, 30-day mortality was 25%. When you have local anesthesia, mortality goes down almost, 2/3 of that. Again, this was shown also in IMPROVE, a trial in England as well, and Canada. So decreased mortality with local versus general anesthesia and endovascular aneurysm repair for ruptured abdominal aortic aneurysm. There's a VQI study that showed basically the patient who underwent EVAR under local anesthesia, they had good chance of survival. And when they compared even to EVAR with general anesthesia, they had better survival with local anesthesia. Obviously, you can't do local anesthesia with open repair. So a lot of patients, about 3,300. So in this study, what they found is basically when you look at the colors, like for open repair, there's the blue, EVAR under GA, and EVAR under local anesthesia. What they found that EVAR under local anesthesia has the lowest cumulative mortality, and that's the 30 days, and then you look at 12 months also, it has the lowest mortality. So if you can do these cases under local, it would help with hypotension, it would help with a lot of stuff. So that's obviously you can't do open triple. In this slide, what we call, or what has been called, aortic clamping prior general anesthesia. If you have an unstable patient or any patient with ruptured aneurysms, and you have the capabilities to place a balloon before induction under local anesthesia first, and then you put a balloon and then you basically induce them, this would be very helpful and actually would not let people to decompensate frequently in terms of blood pressure, because once it's like clamping the aorta, and it has been shown to has a good outcome. And if you look at the clamp sequencing, it's a swallow. You start with a balloon with a 12 or 45 cm 12 French sheath. The balloon should be the sheath should be very close to the balloon. You deploy the EVAR the main body, and then you have, in order for you to cannulate, you have to put a new balloon in the ipsilateral limb and take the balloon off from behind the graft. And basically you cannulate the gate and you go on with your EVAR. A few years back, a new device was released on the market and approved by FDA. It's called Alto from Vascular. This device, I believe, is very useful for ruptured aneurysms if the anatomy is suitable, because this device essentially, the main body contains a built-in balloon, and you place this device, you place the main body, and then you can inflate the balloon immediately after that. So that's a plus and saves a lot of a lot of time, essentially. And this device safety was demonstrated in the Elevate IDE trial, and it has good outcome and safety outcome. Has REVAR improved outcome of ruptured abdominal aortic aneurysms? There are a lot of studies out there that show that, and we will get to that. We'll discuss some of the major reviews and major trials, but there are a lot of studies showed basically the outcome of endovascular repair for ruptured aneurysms, and we'll go through that in more details in the next few slides. If you look at the Cochrane database in 2017, it shows basically for a randomized controlled trial. They found that the patient with AAA, they found the data is available, or they found that there's moderate quality evidence suggesting that there's no difference between EVAR and open repair. The few randomized trial comparing EVAR with open surgical repair of ruptured abdominal aortic aneurysm were poorly designed, and basically some of them are heavily criticized. The short and mid-term survival advantages of endovascular repair remain unclear. There are multiple studies, 26, and most of them, as you see here, they're non-significant. The major trials that talked about discussion, which is the Nottingham, the AJAX, ECAR, and IMPROVE trials, they all looked into basically EVAR and open surgical repair for ruptured aneurysm, and none of them is statistically significant. If you look here, none of these. So the percentage of patients who were included in the study is, if you look, were actually randomized. If you look at the trial and how many patients, is 31%, 22%, 20%, 48%. So 36% total on average that was actually included in the study. So that's not a good number. So issues with these trial results are relevant to those who met the inclusion criteria, results valid to specific centers and practitioners, issues of study interpretations as well. Therefore, there was a VQI study in the US that was very well designed and shed some, it shed some highlight on how to treat these patients and what's the difference between endo and open and so forth. So they looked at a lot of patients for many years, since 2003 to 2018. There are a number of patients, 2,749 patients, versus open repair was about 2,180. They match these patients. They have adequate propensity matching, and what they looked primary and secondary outcome for these patients includes post-operative major adverse event, cardiac, pulmonary, renal, limb ischemia, reoperations, and the 30-day and 1 year mortality rate, multivariate analysis, Kaplan-Meier analysis as well were performed. What they found is basically, if you look at the non-matched for 1 year, what they found basically the EVAR has better survival than open surgery at 1 year. If you have or rupture aneurysms, when you looked at basically matched patient, it's also the same results. So also was comparable results as well. They were a very large study where they looked at approximately 4,600 patients in the early periods from 2004 to 2012. There was very little EVARs were done at that time. Where when you look at the later cohort, between 2013 and 2018, there was a large number of EVARs was done, and 63% of these ruptured abdominal aortic aneurysms were done via EVAR. Open surgery, still a lot of people do basically open repair for ruptured aneurysm when it's needed, meaning if in my practice, if they don't qualify for a quick and sweep endovascular repair, I just do it open, because as I mentioned before, mortality really almost 100% when you try to push the agenda for EVAR when it's not suitable. But this slide would highlight that are still a lot of ruptured aneurysms are done open, but more and more we do an endovascular repair. If you look at the study, there were only 50% of patients were candidate for EVAR, whereas the reason for that is mainly it's an inadequate neck length, unsuitable iliacs, large diameter of the neck, or severe angulation, or whatever reason is. Again, I can't emphasize enough, if you have a patient who does not meet the criteria for EVAR and it's not easy EVAR, do not waste your time, do it open if you want this patient to be alive, in my opinion. And this also been confirmed at least at the University of Seattle, at Harborview, when they actually had 100% mortality in those patients who are not, they underwent EVAR and they're not candidates for EVAR. Whereas if we look at the open surgery, 46% of those patients died and 49 survived. So you better off do it open. You have more chances to actually have patient survive. But if you have a patient who is candidate for EVAR, 85% of those patients survived. So it's a really good advantage, so for that. So type 1 endoleak, it's a problem, especially in rupture aneurysms, because when you have a rupture aneurysms and type 1 leak, you are going to still bleed into the retroperitoneal space, and you haven't really treated that aneurysm. So you do not leave the room when you have type 1 endoleak. It has to be fixed in these patients, and even if you have to open up. Again, like anything else, the more experience you have, the better outcome probably you are going to have. So they looked into a caseload of each surgeon and mortality with elective open abdominal aortic aneurysms, and it was found again, it's the more you do, the better you are, or the better basically survival rate you have. In this study, what they found in terms of excellence, centers of excellence, and the outcome of ruptured abdominal aortic aneurysms. So after EVAR, the mortality was not related to the surgeon volumes. Mortality decreases in high volume centers, and that simply makes sense, because if you have an endovascular experienced center, they can do these cases faster. They have the inventory, they have the tools, the equipment, they have the experience. They do it quickly, and the patients survive. regardless of the surgeon. EVAR is not very hard to do. Probably doing a leg angiogram is harder than doing EVAR. Whereas if you had open surgery, what they found, the higher the surgeon and hospital volume are associated with lower mortality. And again, you need a skilled surgeon to do open surgery, especially with rupture aneurysms. And you need somebody to know what they're doing, and thus the mortality is less if they have a surgeon that has more experience. In this study, what they looked also the outcome after ruptured abdominal aortic aneurysms repair in the era of centralized care. So what they, about 28 or 2,900 patients who presented emergently with ruptured abdominal aortic aneurysm, and 1,246 patients underwent open repair, and 1,649 patients underwent endovascular repair. And what they found, the outcome after ruptured abdominal aortic aneurysm are associated with hospital volume among patients who had open repair, but not among patients who undergoing EVAR. And that confirms the finding from the previous studies. So centralization of care may have an important impact on outcome of open abdominal aortic repair, suggesting benefit of preoperative interfacility transfers to send these patients to an experienced surgeon to do this. Yeah, this is a Cox proportional hazard modeling that shows essentially patients who are treated with ruptured abdominal aortic aneurysms via open repair technique have it's related to the to hospital volume, and basically the more volume the patient has, essentially better chances of survival in this case. If you look at the Cox proportional hazard modeling also for aneurysms who treated with EVAR, what they found here that patient treated with EVAR for aneurysm rupture showed no statistically significant difference in hazard of death based on the hospital volume. So here they just shifted a little bit in this meta-analysis than before. So, but that highlights that EVAR is really you do not need an experienced surgeon. Any surgeon essentially can do that, but you do need an experienced surgeon for open repair, especially in rupture aneurysms. If you look at the nationwide experience with octogenarians, this is a multi-center study that shows about 382 octogenarians with rupture aneurysms treated by EVAR, and 410 treated by open surgery. And by the way, in my practice at least, you can always try to do EVAR on those older population, but if they're not, again, candidate for EVAR, I personally would not hesitate to do these patients open. Because if you do, if they survive, and they leave the hospital, as we will see in this study and my personal experience. If they survive, they do well ultimately. So the preoperative mortality of octogenarians following EVAR was about 37% versus 14% in non-octogenarians. When you look at the open surgery, it was about 68% versus 49%. So again, basically 69% is a high mortality. So survival rate of essentially 30% better than 100% mortality, in my opinion. So mortality rates after ruptured abdominal aortic aneurysms in this group population is high. However, especially with open surgical technique, however, substantial portion of those patients if they recover, they actually do very well in general. Again, it's very important that you have the capabilities of taking care of those patients, because you have to understand that treating these patients surgery is just one station in this patient care. It's a very important station, probably the most important station, but then you have to have adequate ICU nursing. They need to understand what to watch for. For instance, patients who had an EVAR and they developed compartment syndrome for ruptured aneurysms, and that can happen. So you need nurses who understands these complications, and they know how to recognize them and convey that information to the physician. So team is very important in any patient's care, but when it comes to a complex patient's care, such as ruptured aneurysms or other complex surgeries, thoracoabdominal aneurysms, it's crucial to have the appropriate nursing staff so they can recognize. And when you look at this study from Annals of Surgery that showed from Dr. I think from Harborview as well, by Dr. Starnes, they looked into 303 patients who had ruptured aneurysms. 190 patients had an open repair. The rates of ischemic colitis was about 40%, 21%, but 40 patients out of 200, almost 200, had ischemic colitis. That's almost one fourth of these patients. And when you look at the open surgery, endovascular surgery, you see there's only 6 out of 90 patients. So it's a very low percentage to have ischemic colitis in this group of patients. That's why endovascular repair is a very attractive method, but you should not push the envelope to do off-label endovascular repair for ruptured abdominal aortic aneurysm. It's not worth it because patients die. And in these cases, open repair should be considered when you have patients who have thoracoabdominal aneurysms, when you have the free rupture, for example, or patient with calcifications, retroaortic renal vein, horseshoe kidney. Horseshoe kidney it's very hard sometimes to do endovascular repair on those patients because they can have the vessels or the renal arteries, they can come from different places in the aorta. I've had recently horseshoe kidney that was so big that I had to divide the kidney in half and get into the aorta, and then we got urology to fix it, but the patient did well. But sometimes it's hard to do them open as well, but that's one time that you need to do it open because the unpredictable location of renal arteries, and you can have multiple renal arteries in those patients. If you have a large iliac aneurysms, you're not going to spend 4 hours doing IBE and EVAR and this and that. These patients are better to be treated open. This is a large epidemiological study that highlights the rise of usage of EVAR for patients with ruptured aneurysms. It's a very large population, about 65,000 in the ruptured limb and 46 in the intact limb. And they looked into screening and who these patients were screened. There's a lot of patients who were in screening among this population, which highlights it's important to screen patients when they are at the age of 55. And here what they found also in this study, among the 68% of patients who were admitted with ruptured, 59 of those underwent some kind of repair. So the perioperative mortality is about 30 to 50%, and overall mortality is 80 to 90%, really, for ruptured aneurysm. And primarily this mortality can happen in the field or in the place where it's ruptured these patients simply won't make it to the hospital. So the best way to prevent death from rupture is really treat aneurysms in a timely fashion. So 1/3 of these treated ruptured aneurysms in the US were previously diagnosed with abdominal aortic aneurysm. They either lost their insurances or lost to follow-up or what have you. So surveillance gap increases the likelihood of rupture sixfold. So if you have gaps in surveillance, will increase the likelihood that the patient will rupture about 6 times more than those who actually don't have gaps and they follow the surveillance. I just wanted to mention that we're seeing more and more these days. Actually, most of ruptures that I see, it's patients who have had EVARs. So we basically, if it's not easy endovascular repair, such as the type 1A or type 1B that you can put a cuff or put a whatever to fix it, I just do them open and take the EVAR out or a stent out and treat it with a tube graft if it can be done. In summary, endovascular therapy has been shown to have better outcome than open surgery when the anatomy is suitable. When the anatomy is not suitable, these patients should have an open surgery. Otherwise, the mortality approaches 100% when you push the envelope. System protocols has improved survival. We saw this in multiple studies. Centralization is important when it comes to open surgery, and the outcome of open surgery really has not really changed in the past 2 decades, because we still have people who know how to do open surgery, but the future we may be in a little bit of a trouble in this area. Therefore, multiple institutions now, they focus on the effort of teaching trainees how to do open surgery rather than just endovascular surgery for these patients. There's a need to increase screening for abdominal aortic aneurysm, because once you screen those patients and they have aneurysms, you put them on the watch and you watch them, and that way you prevent rupture. That's all what I have to say, and thank you very much. If you have questions, you're welcome to send me a message on and I'm happy to answer them. Thank you.